monitor the operations of the organization as they pertain to security and privacy. The site visit will be followed by a draft report that will be shared with the entity for comment and corrective action, and then the comments of the entity will be incorporated into the final program. The entities will not be identified in any way, nor will results be posted in a way that identifies them. So this is very significant for EHRs because they are, of course, a primary mechanism for monitoring compliance and recording compliance. OCR is saying that the audits are primarily a compliance improvement activity, and should an audit reveal serious noncompliance, OCR will initiate a compliance review. And with that, I'll turn it over to Jim.
Thanks, Mike. Yeah, we thought both because it was a new development and because most of your EHR systems are that provide a prime audit trail of access to the HIPAA-related information or HIPAA-protected information that we wanted to bring that to your attention. We're now going to move, and the rest of the program actually it's a survey of issues, some new that you may not have thought about as much, and some that you've, I'm sure, have heard about and spent a lot of time on, but kind of reviewing some important elements. The next issue, the key issue, is a discussion about meaningful use in general, and some specifics about what vendors are doing in terms of assurance of meaningful use, issues that we're seeing with doctor or physician adoption of EHR technology, and then that will roll somewhat seamlessly into a discussion of as you are either in the midst of or developing your physician outreach programs, some issues for consideration. And I'm going to kick it to Rick Reifenbach to start, and then Dan's going to take over, and they're going to kind of dialogue back and forth on these issues. So, Rick?
Thanks, Jim. As many of you are probably well aware, the American Recovery and Reinvestment Act of 2009 allocates billions of dollars in incentive payments to encourage the adoption of EHR technology between 2011 and 2021. And certain hospitals and eligible professionals, and we're going to refer to them as EPs, may qualify for the payments if they make meaningful use of certified EHR technology. And Dan is going to review what those terms mean. We don't have time today for an exhaustive review of the EHR incentive program. That could really be a webinar into itself. But we are going to cover some of the high points and some practical issues. The EHR incentive program adopts something of a carrot and stick approach to EHR adoption. The carrot is in the form of these incentive payments, which for EPs under the Medicare incentive program are $44,000 over 5 years and $63,750 over 6 years under the Medicaid program. And for hospitals, it depends on a number of different factors, but those payments begin with a base payment of $2 million. Now, the stick under the Medicare EHR incentive program is in the form of a Medicare reimbursement penalty, which occurs in 2015, to the extent that EPs and hospitals at that time have not made meaningful use of EHR technology. And as I've mentioned, there are two incentive programs. There's the Medicare incentive program and also the Medicaid incentive program. And hospitals can participate in both of those programs, but EPs must choose one or the other. And with that, I'm going to turn it over to Dan.
Thank you, Rick. So what I would like to go over is basically, there's three essential requirements to get the incentive payment. This is what the EPs are going for. They've got to show meaningful use of certified EHR technology, which is a defined term, some level of interoperability, use of EHR technology to exchange health information to improve quality of care, and submission of clinical quality measures to CMS. So there are a couple bullets in there indicating, I'm sure most of you are familiar with this, the 15 core and 5 of the 10 menu set objectives and related measures that have to be met and demonstrated. Initially in stage 1 and during 2011, attestation is required to demonstrate meaningful use, which means you've got to sign a document attesting what you've done on these measures. In 2011, it's with respect to a 90-day period, so the last 90-day period is the one that we're in now, that a lot of EPs are chasing. Beginning after 2011, 2012, there may be the requirement to submit directly to CMS on the clinical quality measures. That's a little bit controversial right now, and whether the industry is ready has also been challenged, but that's currently what's on the calendar. So let me just talk.
Dan,
yeah.
Dan, one second, this is Jim. We're also just on the attestation, even though the requirement is just the attestation, we are suggesting that to the extent screenshots and other things can be taken that demonstrate how the various meaningful use requirements are being achieved, that it's not a bad idea to have that in your file so that if somebody does come back and look, that you have kind of that footprint.
I think that's a great idea. It's important to keep the evidence to be able to show it if there's ever an audit looking for it. So if your EHR system doesn't record it, then it's a good idea to keep that evidence. I just wanted to quickly go through what certified EHR technology is. It is a qualified EHR that has met the certification requirements established by the Office of the National Coordinator for Health IT. It can be either a complete EHR or an accumulation of EHR modules, which together constitute a qualified EHR that meets the certification requirements.
And Dan, another point on that. In our first session in this series, we talked about procuring EHR technology, and one of the things now that there's the ONC ATCB certification, and there are other certifying entities out there. Those are very good, but you have to also understand that certification in and of itself, it tells part of the story, but it doesn't necessarily bring any protections forward to you other than the knowledge that some testing has been done and a third party has given them a stamp of approval, and the technology will qualify for meaningful use. So the point is that when you're looking at your own warranties and your own protections that you want to ensure that certain features and functions are there, you still need to make sure that you've identified and included those in whatever agreement you have with your particular EHR vendor.
Sure, absolutely. And the other thing that you may want to consider is your EHR technology going to get you to meaningful use? It may have the features and functions that you need, or that at least that satisfy the ONC ATCB requirements, but will you get your incentive payments? So that's a big question that's out there, and what I wanted to go through on this slide is kind of how some vendors are responding to that. In the contracting process, that's a big question. And there have been various responses. There's a whole spectrum. Some of them are saying that, and this is kind of from least to most in terms of what the vendors are promising they're going to get you. It currently qualifies as certified EHR technology. That's great, but will it qualify as the certification criteria change over time? So it's legitimate to ask that. Will it qualify next year and the year after? Will you give me a warranty to that? And not only that, but then will there be any, will it enable me to get my incentive payments? It's one thing to be certified EHR technology. Does it have the functionality to do the reporting to keep the evidence that you need to get the incentive payments. So some vendors are putting in contractual language that addresses that, and then some of them are going further and giving some specific guarantees, putting some skin in the game. In some cases, financial guarantees. For instance, if it doesn't meet the criteria for certified EHR technology, I think that's what most of them are. There may be some who are guaranteeing some meaningful use incentive payment, and if the practice does whatever it's supposed to do to record the information to meet the measures and objectives under meaningful use, and there is no payment at the end of the day, having to do with the functionality or the service that's engaged, and there may be a guaranteed some guaranteed compensation for that.
And Dan, Jim, again, I think that we see this all the time in the transactions that we're structuring, and there's always a significant discussion with the vendors about this. And there does have to be an inherent fairness, because of course there are things that the customer, the healthcare organization, the physicians have to do to achieve meaningful use. And so the key phrase that Dan used, I think, is important, is the delivering the functionality to enable achievement of meaningful use, and then to connect that promise of delivering the functionality to, if that functionality is at fault or is at risk, or put your meaningful use payments at risk, what will the consequence or the accountability of the vendor be for that? And the other element that Dan raises, I think, is really important, is this concept of the evergreen nature of it remaining certified EHR technology and evolving to allow you to achieve meaningful use. They're obviously evolving the requirements for the subsequent phases, and we're not sure what those will all be, but the last thing you want to do is have a big hit, another financial hit, to achieve the next phase of meaningful use. That needs to be part of the deal.
That's a great point. Yeah.
That's the business the vendors are in. That's what you're buying, and you just need to make that bargain.
I agree with that. Great points. Let me share with you now some data that we've collected at Athena Health that I think is just very interesting in terms of, at this early stage, at the end of 2011, first attestation year, how providers are doing. What are they struggling with on some of these objectives and measures? And this is what we've collected, kind of the top 4 areas where some of our providers had difficulty and where we tried to help them get there. Providing clinical summaries. So one of the requirements is to provide clinical summaries to patients for at least 50% of all office visits within 3 days of the visit. And this is something that requires the physician or other practitioner to really participate to achieve compliance. They've got to get that summary out. So we saw that level kind of falling below a lot of the other levels, and kind of intervene to provide reminders and training on that. Recording demographic information. Some of the information is a little bit sensitive, like race and ethnicity, and we were finding that some of the providers weren't collecting it, or there might have been some other reason they weren't recording demographic information. Some of them don't, sometimes it's not collected during each visit and it was missed. Recording vital signs, there's certainly some specialists who don't record that or don't record it at every visit. So the measure there is height, weight, blood pressure as structured data in the EHR for more than 50% of all unique patients. So, and then finally, the security measure, protecting electronic health information. This is one where you really don't have much on the vendor side to do about it. It's really left to the practice. and hard to measure. But the polls that we've seen in the industry and that we've done ourselves indicate that there's some spotty compliance. So these, perhaps can be taken of areas of, of additional focus for those of you involved in attestation. I'm sure there are others. And then more broadly speaking, I think that the ONC has become concerned about some of these areas where providers are having difficulty, and at some point might step in and provide some guidance or some further guidance on how to accomplishment or maybe even modification in the future of the meaningful use measures. And I think that.
Well, thanks, Dan. Yeah, that'll take us back to Rick, who's going to talk a little bit more about the incentive programs, and for many of you are already involved in a very significant way in physician outreach programs. Some of you are evolving them as we speak. Wherever you are, you can either take Rick's comments as a way of checking what you're doing or helping you evolve what you are planning to do. So, Rick, why don't I turn it back to you?
Thanks, Jim. Yeah, we wanted to cover just a number of practical issues that are coming up with clients and that we're seeing in the industry. The first is the exclusion of hospital-based EPs from the EHR incentive programs. And the point there is that not all EPs will qualify for the incentive payments, even if they are using the technology. Those who perform 90% of their professional services in either inpatient departments, which are defined as place of service code 21, or the emergency room, which is place of service code 23, are excluded from these programs. Originally, EPs who are in the outpatient departments of hospitals were also excluded from the program, but that limitation was actually removed by legislation last year. So the next point is Medicare versus Medicaid EHR incentive payments for EPs. As I alluded to earlier, unlike hospitals, which can participate in both those programs, EPs have to pick one or the other. Medicare pays these doctors these EPs $44,000 over 5 years, whereas Medicaid, the incentive payments are almost $64,000 over 6 years. However, under the Medicaid program, an EP must satisfy a Medicaid patient volume requirement, and for most physicians and other professionals, it's 30% of their practice. Before 2015, an EP may switch between these programs once after the first incentive payment is initiated. So to the extent that a situation changes and maybe an EP is able to qualify under the more lucrative Medicaid incentive program, then there would be an option to do that. Next issue is the reassignment of EHR incentive payments. This would come up in the context of employed EPs or other EPs that contract with entities that bill and collect their professional fees. CMS has indicated that those EPs may reassign their incentive payments to those employers who very likely would have provided the technology that the EPs are using. However, the parties will need to take a look at their current contractual relationships. CMS defers to the parties in their contracts to determine who is entitled to those payments. And to the extent that that's not contemplated by the contracts, the parties can enter into a contractual amendment to then reassign those incentive payments. So I think the takeaway on that issue is be sure to check the contracts with your employed physicians or other professionals. The last point here, and we alluded to this earlier, is the importance of maintaining documentation to support the meaningful use attestation. In fact, it's required under the regulations that EPs and hospitals maintain that documentation for 6 years. And so you're going to want to have that handy in the event of an audit. And then one final point I just wanted to mention here that's not on the slides are that the recent ACO regulations came out last month, very recent. The proposed ACO rules had originally required that half of all of the ACO's primary care physicians must meet meaningful use by the second year of the ACO, the life of the ACO, in order to continue to participate in that Medicare Shared Savings Program. Now, the final rule, which again came out last month, eliminates that requirement. However, EHR is still an extremely important part of any ACO. In fact, there are a number of different quality measures that have to be satisfied in order to be eligible for those ACO payments, and one of which is that it's based on how many of the physicians have received EHR incentive payments. In fact, that's the most heavily weighted of the measures. So the next thing we want to talk about are EHR incentive subsidy programs. The incentive programs we just talked about provide incentive payments for EPs to use EHR technology. However, that doesn't necessarily solve the problem that many EPs face of how do they afford the technology in the first place. So to help facilitate the adoption of EHR in their communities, some hospitals and different types of entities may subsidize their EHR technology for the community physicians. Now, prior to 2006, these types of programs were very limited because of the Stark and anti-kickback statute rules which restrict financial relationships between physicians and entities to which they refer patients and other types of Medicare and Medicaid business. However, in 2006, regulations were promulgated under Stark and the anti-kickback statute to help facilitate the adoption and the donation of this EHR technology. So what types of technology can be subsidized under these programs? It's different types of software and other related services that are used predominantly to create, transmit, and receive EHR. And we've included here on this slide some of the bullet points regarding the different types of technology and services that can be subsidized for the physicians. Things like licenses and IP related to EHR software and different types of connectivity services, as well as help desk services. And so we wanted to, next slide.
So, Rick, a question that I have often got from clients is, well, what if the EHR comes with a physician practice management program? Can I give them both the, can I subsidize both the EHR component and the practice management component? How does that work?
Right. Now that's a good question. Now that's something that is addressed in the preambles to the regulations, because that's a very practical issue, that a lot of the technology, the EHR software packages include practice management software and other types of billing software. And the regulations do provide that to the extent that that other ancillary software and functionality is included, it may be subsidized as well, as long as the EHR component of that software package predominates. So it can be included.
And has there been any interpretation of what predominates means, or is it like it sounds, which is kind of more than 50%?
Yeah, I mean, there hasn't been any official guidance on that point. I would say it's a facts and circumstances test, based on the software package.
Okay.
So then we wanted to run through some of the more specific requirements here of the EHR regulations. The first, and this is a theme through the EHR regulations as well as obviously the EHR incentive program, is that the technology must be interoperable. It must be able to communicate with other types of entities and other types of technology, and the donating entity cannot limit or restrict the use of that EHR that's donated. Another important point is that there is a physician cost-sharing component to the donation. The donating entity must calculate its cost for the technology and the help desk services and any other ancillary services that are protected under these regulations. And the physician must pay 15% of those costs in advance. Now, to the extent that you have ongoing fees, they can be paid on a rolling basis as long as the physician is making the cost-sharing contribution in advance of those services being provided.
So the physician would have to pay, let's say if you had a monthly fee of some kind, you would want to set up some account that's being replenished by the physician in advance of that next month's services.
That's right. That's right. But to the extent that you had startup costs, you would want the physician to pay his or her 15% of the startup costs prior to receiving that technology in the first place. Physician eligibility for these types of programs, there's a requirement that the selection process, the selection criteria, not directly take into account referrals from the physician to the donating entity. CMS and the OIG were a little bit looser on this requirement than they are in some of the other regulations because you can indirectly take into account referrals. And the regulations provide a list of different criteria which they consider to be deemed not to directly take into account referrals. An important requirement is that the entire arrangement be reduced to writing. This is a theme through many of the Stark and anti-kickback statute exceptions and safe harbors. That agreement must specify the items and services being provided as well as the cost of the items and the physician's contribution. So it's all going to be in writing in a signed agreement between the parties. Okay, the donating entity cannot donate the technology to a physician if that physician already has equivalent technology. And again, that's likely going to be a facts and circumstances type test. And the concern here that's being addressed is that if you donate something that the physician already has, that physician could put that technology to some other use or somehow benefit from that other technology in a way that might look like a kickback or an inappropriate inducement.
So Rick, what if a physician has a system or a group has a system? It's a pretty good system, but it's not certified EHR technology. Would that be something that would be considered, equivalent?
Yeah, in that situation, I don't think it would be equivalent. I think that to the extent you're going from technology that's not certified to technology that is certified, that would not be substantially equivalent. And preambles are pretty clear that, to the extent that you're upgrading the technology, that is permitted.
This is Dan. Can I just make another observation there? In that some of the quality management programs, run by health systems or payers, where they're asking for data collection to support pay for performance or other quality management. One question that's out there is, if you notwithstanding the certified EHR technology, if you have two systems that are certified EHR technology, but one is capable of those data capture requirement and reporting requirements to support quality management, does that make it not substantially equivalent? And I think there's a view to be expressed that upgrading to those capabilities would not be substantially equivalent.
Yeah, good point. The last point we want to make on this slide is that the donated items and services can include the hospital sending over personnel to help the physician, for example, convert the paper records into electronic form. So that's a question that actually comes up pretty often. Okay, the last requirement we just wanted to list here, and I should say that we just hit the high points here, are some of the key requirements of this regulation. There are a few other requirements that we didn't mention, but the Stark and the EHR and the anti-kickback statute EHR exceptions sunset on December 31st, 2013, and so they are not at this point permanent. Although I've seen a number of industry comments on this, and they've sent letters to CMS requesting that these exceptions that they are extended. But because of this sunset, which when these regulations were promulgated back in 2006 seemed very far away, but at this point it is around the corner. And so in your donated items and services agreement, you need to allow for the fact that the subsidies must end on December 31st, 2013, and allow, to the extent that the physician no longer wants to pay or is not willing to pay for 100% of the technology, that you have a mechanism in place to get the information and the data that's on the EHR back in a format over to the physician so that there isn't any interruption in patient care. So,
and we've heard a lot of back and forth on this issue. I mean, obviously, the traction that they expected in 2006 didn't really pick up until the incentive program was implemented, and so people are not as far downstream as I think they in the Congress originally thought they would be. But what happens if you've got a monthly, let's say a monthly program, and some doctor's share of the program is X $100 a month, and this program ends at December 31st, 2013, and they do not extend it, which we don't know, but assume that happens. then the doctor would be responsible not only for his or her share, but for the entire share if they were going to continue using the program. So all the investments that are being made with the assumption that the input and the participation of the physicians in the program will remain come into a bit of question. And is it a legitimate thing to be looking at? Is there a way, let's say the hospital could buy a license today that would be a perpetual license and pay X amount, and the physician would pay, their 15%. Would that license, that transaction would be protected, wouldn't it?
Yeah, I think I would argue that it would be, because the specific aspect of this regulation that deals with the sunset says that all the subsidy and the transfer of the license and the technology must have been completed by December 31st, 2013. So if that's a situation where essentially the technology was sold to the physician, I would think at that point there's no subsidy and the transfer has already occurred.
Interesting.
One thing that we struggled with when these regs were proposed, this is Dan, is the coverage of the technology. Originally in the proposed rule, it only covered software, and in the final rule, we commented on it. I'm sure it's not attributable to us, but it covered services as well. So there's a question when you're actually on a subscription service model providing EHR and not transfer of a license, whether that would still hold true. Not to debate your point, but it's maybe a little bit more of a question.
So you're talking about is a subscription model a service or software, and
right.
Interesting.
Right. So we that's actually something we would look at. Haven't really looked at it yet. Towards 2013 is whether we'd also feel comfortable under the safe harbor, if it weren't extended. Okay, just to close out this slide, I wanted to mention some other additional considerations. The first is you need to check your state laws in connection with any EHR donation program. Some states, or many states have Stark and anti-kickback statute counterparts, some of which have EHR type exceptions, some don't, so you need to take a close look and make sure that your program complies under your state law. Obviously, patient privacy laws are central to EHR programs. There's also IRS guidance for tax-exempt entities that was issued back in 2007, and there's some additional FAQs that the IRS released following to provide their guidance and their rules regarding when these programs are acceptable and won't jeopardize the tax-exempt status of an entity. They generally incorporate the federal anti-kickback statute and Stark exceptions, but they are different in some respects. And then lastly, just wanted to mention, again, the ACO rules, which came out last month, and one component of those rules is a waiver of the Stark and anti-kickback statute in certain situations in connection with ACO activities. And so to the extent that a hospital or another entity is participating in an ACO, there may be an opportunity to donate 100% of the cost of the technology without the cost-sharing requirements. So you need to take a look at those ACO rules if that's your situation. Although I would just note again that the ACO rules do not waive state laws, so you'd want to check your state laws to make sure that any donation in that nature would comply. So thank you.
Thanks, Rick. Now we're going to take a transition here from some of the specific meaningful use requirements and the physician outreach approach and incentive programs to kind of a technology concept that all of you I know are very familiar with, cloud computing. It's everybody, my own personal observation has been that whoever came up with the phrase cloud computing is one of the most brilliant marketers of all time, because I can't tell you the number of times I actually hear clients and potential technology purchasers saying, well, it's not a problem because it's in the cloud, or yeah, we can do this because it's in the cloud. There's a perception that any technology that is labeled cloud is the right technology. And frankly, that can be true and it can be false. And what we want to do in this segment is try to help you understand a little bit more about cloud technology and when you can and should have comfort in some of the great advantages that it supplies, and when you can and should be cautious and very thoughtful about using it for a particular function. And to do that, it's going to be my partner in our information technology and outsourcing practice, Chanley Howell, and Dan again, and they will walk us through this. Chanley, why don't you take off?
Sure. Thanks, Jim. You know, in cloud computing, as you alluded to, Jim, can mean different things to different people, but at its most basic level, and the way we'll talk about it today in the remaining time we have left, and then we are saving time for questions at the end, it's basically an IT solution where the data and the software are hosted remotely. So that covers a lot of ground, and it's, as you probably know, and as Jim pointed out, it's becoming very, very common. And while it may or may not be an entire EHR system, it may be an EHR module, or it just may be part of your software portfolio. But if you haven't, or your organization has not been exposed to cloud computing or adopted it on some level or another, it likely will in the very near future. So it's important to understand the unique issues that are presented by cloud computing as opposed to the more traditional software model. It raises new issues that we'll touch on, and it sort of changes the emphasis, turns the table a little bit on some of the traditional issues that have to be dealt with in the cloud computing context. So one of the main risks in dealing with cloud computing is this privacy and security risk, and Dan will talk about that in a little more detail. But this slide that we've entitled Cloud Risk Assessment Matrix is a basic model that we use with clients and recommend to clients for assessing what level of due diligence and caution they should take when approaching adopting a particular cloud solution. So depending on two factors. One is the data sensitivity that runs along the left side, and then across the bottom is the criticality of the service. And with cloud computing, it's a remote solution, so it adds lots of uncertainty and variables in between your computers and where the data and the software resides. So if it's a high risk on, or if it's a high rating on either the data sensitivity or criticality of the service or both, then the higher it is and the more closely that the risk should be analyzed. With an EHR system, it's likely going to be high on both. But you could still have modules or for example, maybe certain practice management pieces that may not be as critical on the data sensitivity, but still a critical service and needs close attention.
And Chanley, I was just going to say, if you back up for a second onto that risk analysis, risk assessment matrix. You know, several years ago, as the cloud was coming to the fore, you know, in our practice, we were seeing what I guess I would steal a phrase from the last decade, an irrational exuberance associated with movement to the cloud. And we were looking for a way to help our clients address this issue because we, like so many others, believe there's great benefits in the cloud, but that it needs to be thoughtful in terms of whether it is the right or wrong solution in a particular case. So we developed a white paper that really goes into extraordinary detail on these cloud issues, and this is kind of the cornerstone of that paper, but we go into a lot more detail on those things, and we have found, and our clients have seemed to have found that this simple approach has been very useful in their assessments. All right, Chandler.
Right, thanks. Yep, good point. The next thing I wanted to touch on and recommend for reading, if you haven't seen it, is NIST, National Institute for Standards and Technology, recently came out with a roadmap for cloud computing. You can get it at the NIST website, www.nist.gov. Very easy to find through a Google search. And basically, the roadmap has 10 requirements or goals, which we've put on the slides. I'm not going to go into detail on all of them, but I do recommend it for anyone who's involved or looking to get involved in a cloud computing solution. It's basically a guide of what the government sees as important factors and important development for cloud computing. And as we all know, the government can be very and is very influential in shaping the direction of an industry. And while the document is not EHR specific, as you probably know, NIST is very involved in the whole EHR certification and adoption process. So it really provides a lot of useful guidance and a roadmap and visibility into where the government at least wants to push the industry. I just want to mention that, you know, if you're part of the legal team or a business team working with the legal team on adopting a cloud solution, I would point out on this slide, the third and the fourth bullet, and these are all discussed in the roadmap. The third one is technical specifications for high-quality service level agreements. So basically, it's a description that for cloud computing to really have an appropriate level of adoption, there really needs to be consistency in service level agreements, and the roadmap goes through various issues and what should be dealt with in the various service level agreements, and with the goal towards reaching some consistency in what the SLAs contain so that there can be some objective apples-to-apples comparison. The fourth bullet on this page is that there should be clear and consistently categorized cloud services. Again, cloud in whether you call it application service provider model, ASP, software as a service, platform as a service, infrastructure as a service. There's lots of buzzwords and different names for the services, but it's important for there to be consistency. And when you're working on acquiring a solution and working on the agreement, if you're part of the agreement process and the negotiation process, it's very important to have a clear description of what the services are. And the third part of the roadmap I would recommend to you if you're part of the legal or the business team is the last one on this bullet, which the roadmap discusses how and why there should be defined and implemented cloud service metrics. And this is a little bit similar to the first two, and why I pointed them out is that there is a need in the documentation and contracting process and acquisition process that there be consistency in describing essentially what you're buying. And here, this deals with the metrics such as availability, the throughput, the amount of storage, the different measurables so that customers can properly assess what a fair price is for the service that they're buying. So that's an overview of the roadmap. Again, I recommend it while it does contain a fair bit of policy as well as technical language, there's also a great deal of discussion of legal issues and business issues. So Dan, I'll flip it to you, and I think you were going to dig down a little deeper on some of the issues that implicate the pros and cons of cloud computing.
Absolutely. Thank you, Chanley. So we've already talked about what cloud computing is. I'm going to skip over that. I've got another great NIST document that I'm kind of using as a reference, which is this Guidelines on Security and Privacy in Public Cloud Computing. And I found it as a kind of a useful enumeration it has a useful enumeration in there of disadvantages and advantages from a security standpoint. So I just wanted to mention a few of those. We have limited time, so I'm not going to go through all of the bullets here. I'm going to start with some of the concerns that are often expressed. Obviously, in healthcare, the nature of the data is critical. It's not that critical in some other industries, but protected health information obviously is, and that kind of gives it a different, cast or character to the issues involved in security here. It's really important. You've also obviously got the HIPAA security rule and potentially other standards that apply depending on the data that you handle. For instance, if you store Social Security numbers, there will be other data breach requirements that apply. So the objection I see a lot is the last bullet on this slide, loss of control. So especially in larger health systems or hospitals that have a CIO, they like to control the security measures that apply to the data. And it's a big leap of faith to delegate it to a third party. So that's the objection I see most often. Logical separation, if you're in a multi-tenant environment in the cloud, that means your neighbors may be, data may be on the same server, so it requires computer code to basically, it's not a physical separation, to create that separation between the different data tables. But things like that, I think, are becoming more accepted. The loss of control is kind of a big operational administrative issue. Some people just have a really hard time with.
So Dan, on the loss of control, though, that could be a very, that's an important, very important concept to be concerned about. And the answer that the vendor you're dealing with about how they address security is really what the customer should be looking at in terms of do these people know and are they professional at managing security, correct?
Yeah, and I'm going to go to that slide now that you mentioned it, because it's probably the most important one here, is conduct your diligence on your vendor. At the end of the day, it's really the same as most other security diligence, but because you may be delegating some of these security-related functions specifically, you want to ask some questions and get comfortable with the vendor. So ask them, if they've conducted their HIPAA security risk assessment. Do they have a statement of security measures that they'd be willing to share? How deep are they willing to go into that? Will they be willing to let you speak with a security officer, chief information security, or other individual if you have more specific concerns? And then, if it's important to your operations, understand what the disaster, what recovery points are, recovery times for the data, especially if it's clinical data. That's going to be really important. So I think that, when I negotiate contracts, a lot of the times, I'll find myself saying, we shouldn't be talking about the liability provision so much. Yes, we should talk about liability and indemnity. It's absolutely relevant. But to get you more comfortable, do more diligence. We'd be happy to show you some more things, or give you some people to talk to about some specific questions. So that's really important. I'll just go back up here to some of the security advantages because there are advantages, I think. I think the big one is what's often touted as an advantage of the cloud, which is availability. And I would go back to the HIPAA security rule and a three-leg stool where the three major security elements are confidentiality, integrity, and availability. And I think availability sometimes gets forgotten as a security element, and that's, good patient access. If a data center goes down, is there a redundant data center somewhere else which can pick up that data in a natural disaster or just an outage or some other circumstance? Some built-in redundancy, things like that. Again, not all cloud is created equal, so some of them are going to be very good at that, some of them less so. And then another thing, just economies of scale. A well-established vendor that has a good reputation is going to have the ability to put some really great security personnel and technical measures on this. that other organizations that don't have the same type of funding might not have. So you might actually be losing some control in some instances, but gaining some of these economies of scale and expertise.
Yeah, Dan, if I can jump in on that point, the comparison or balancing of the loss of control versus these points of staff specialization in the experts in security, for example, reminds me of the story about Willie Sutton, the famous bank robber. And they asked him, well, why do you rob banks? And he said, well, that's where all the money is. Well, that's what scares a lot of organizations in moving to the cloud is that, if I'm not a large organization, I may be under the radar, but if I move my data to the cloud, is it now going to be the target of hackers or identity theft, et cetera? The flip side of that, though, is people keep their money in banks because they are secure. They're more secure than your mattress typically. So,
great analogy.
As you say, it's not for every organization. It's not for every solution. But when you look at the advantages and disadvantages, and as long as you do your due diligence, you can come up with the right decision.
Right. Great.
So, guys, Dan, I'm going to move us to our last topic because we did want to try to end at the top of the hour and then take some questions. But I do there was a question from the group about the availability, and we will be getting this deck to everybody on the call. And also, if there's any interest in the white paper that we discussed, we're pleased to get that out to you also. Dan, why don't you take us through this last issue that just came up?
Okay, sure. Yeah, and this is, I just wanted to give an overview of some potential expansion of EHR regulation, as if we don't already have enough with the ONC, Authorized Testing Certification Body, Certified EHR Technology. There's been kind of talk from time to time about the FDA regulating EHRs as a medical device, either under a pre-market approval approach, this is the second bullet, or looking at the integration of medical device data systems. There's actually a rule on this, which could be interpreted as subjecting at least parts of EHRs to Class 1 medical device regulation. But the recent development is the top bullet. The Institute of Medicine putting out some recommendations on patient safety, and all of these efforts really have to do with patient safety concerns of EHRs, data integrity, is the clinician getting the right information at the right time, are dosages being reported and other lab values being reported correctly, that type of thing, which are really critical concerns. And it's great that there's attention on them. Whether we need more regulation or another entity to look at it, as the Institute of Medicine has recommended, is a big question. I would suggest that it should be streamlined in some way, and let's have one body do it. That's my personal opinion, whether it's ONC or somebody else. But the concerns they expressed are about these adverse events that could arise from data coming out of, or functionality within EHRs, and I just wanted to point that out. That is also available with an easy web search if you want to read the whole thing. And then just wanted to point out that there are self-regulatory efforts alluded to by the Institute of Medicine, like voluntary adverse event reporting to an organization called iHealth Alliance. There are others, and those have been kind of endorsed by the FDA. Kind of puts the information out there. I think it might be a good approach for the industry, kind of similar to the payment card industry's approach with their self-regulation. If you do it yourself and really get ahead of patient safety, maybe you won't have 3 regulators.
Yeah, good point. I don't know that anybody feels we need another set of regulations or regulators in this area. Well, thank you very much to this panel, Chanley, Mike, Dan, and Rick. And we're at the end of the formal program, and wanted to open this up for questions and answers. Before we do, just remind you real quick that the next two in the series here there's a program on privacy and security in high tech on December 16th, and then there's another program on emerging issues in health information technology. And our first program that we did at the end of October on procuring health information technology is available on our Foley website also, the deck for that program. But are there questions from the crowd? And if you could direct it to an area of content, that'd be great.
Thank you. Ladies and gentlemen, if you have a question, please press star then one. And once again, if you have a question at this time, please press star then one.
Well, while we wait and see if somebody formulates a question, we do, again, just want to thank you all. There was a big attendance on this program. We hope you enjoyed the content. As we said, we'll be getting it to you and look forward to your participation on our next event in this series. We'll give it one last shot in terms of if there are any questions, and then we will adjourn.
We'd like to encourage you to fill out the evaluations, and also would remind you that you can apply for, or we've applied for 1.5 hours of CLE credit for the program.
And I'm showing we have a question. And our first question comes from Pamela Hawthorne. Your line is open.
Thank you. This is Pamela Hawthorne, and I have a question regarding the eligible professionals. Within the regulations, it says that they need to meet for Medicaid purposes, they need to meet the 30% or greater criteria. And I'm wondering if a professional is a locum that provides service to a provider-based clinic, do we need to exclude those services provided there when we're trying to determine the 30%?
I'm going to have Rick answer or ask for additional information that he might need.
Okay.
Yeah, to be honest, off the top of my head, I don't know the answer to that. I think I'd have to look into it. Maybe I could follow up with you offline if you shoot me an email with your contact information.
Okay, that'd be great. Thank you.
Yeah.
Thank you.
Any other questions?
I'm not showing any further questions.
All right. Thank you all very much. We really appreciate your time.
Thank you.
That will conclude the call.
Thank you. Ladies and gentlemen, this does conclude today's conference call. You may now disconnect. Speakers remain online.